Thanks for the invitation to this course. I'll be speaking on parasites in the organ. The presentations can be extremely varied. This 20-year-old male presented with diplopia, worse in upward gaze. This boy primarily presented with a forward bulge of right eye for a period of 1 month. This 16-year-old boy presented with diplopia and proptosis, the diplopia getting worse in the right gaze. This girl presented with a swelling at the medial canthal region under the conjunctiva. This boy had recurrent episodes of swelling causing eyelid droop on each of the occasions. This female had been having recurrent episodes of redness and an inflammation, was being treated as a patient of non-specific orbital inflammation and had received steroids and had had partial response on each of those occasions. This girl presented like an orbital cellulitis. She presented with acute swelling, drooping, double vision, suggestive of an acute orbital inflammation. This male presented with an abscess appearing under the temporal conjunctiva and pointing as an external pus point. What was common amongst all these patients? The imaging in all of these patients showed a cysticercosis, a parasite. This is the first male with diplopia and ocular mobility restriction, and what you find is a parasite in the inferior leg fascia. This 8-year-old boy with proptosis also having an enlarged muscle with a cysticercus. This boy with proptosis and double vision again had a muscle swelling and an parasitic cyst. The subclavian cyst or mass was also a thickened muscle with a cystic area with a scoliosis. The one with recurrentosis, presenting with recurrent episodes of inflammation in the superior orbit, again had a parasite in the superior rectus muscle and the scoliosis is visible. This girl also turned out to be the one with recurrent attacks of inflammation treated as non-specific orbital inflammation, also had a cysticercosis. And the same was true for the girl with presentation as an acute inflammation where there was an enlarged superior rectus muscle with a cyst and a scoliosis. Subconjunctival abscess, when it was drained out, showed a cysticercus cyst with scoliosis coming out. So all of these are orbital myocysticercosis. So we need to be familiar with all these presentations and pick up these cases clinically as well as follow it up with the radiological or imaging to establish the diagnosis. We know that cysticercosis occurs is caused by the larval form of Taenia soli. It is prevalent in several parts of the world. It is one of the common causes of proptosis in India. We know that humans are accidental intermediate hosts, the definitive host, the human adults, and the intermediate hosts are the pigs. But the cysticercus form is when you are ingesting the eggs from the feces and these develop into cysticerci in the muscle and the brain. So ingestion of contaminated food, specifically with salads which are non-cooked and not cleaned well enough, are the commonest source of infection or infestation in India. There can be systemic involvement involving all these tissues, and eye is not such an uncommon presentation. You can have the intraocular manifestations, which you are all familiar with, and the extraocular ones which involve the muscles and the subcutaneous area. In the series of 181 cases that we have seen, there is a slight male predilection and age group varying from children to late adulthood. The ocular motility restriction is the commonest presentation. Proptosis is a common manifestation. Recurrent episodes of redness, swelling and pain are a fairly frequent presentation, and they must be a cause for thinking about cysticercosis. But presentation as a recurrent ptosis is something that really needs to be watched out. The various muscles are involved in the myocystic but lateral rectus is the one that is most commonly involved. The diagnosis is clinical and imaging. Serology does not contribute much to the diagnosis and is often negative. The CT scan, it is important to ask for 1 or 2 millimeter cut so as to not miss out the cyst. So when you see the hypodense cyst with an hyperdense cortex, that is a very clear indication of myocystic and a surrounding myositis is very characteristic. This is a superior rectus involvement that you can see here. MRI gives a very good soft tissue delineation as well and demonstrates the cyst with surrounding inflammation very well, and you can see the epichaetous cortex quite easily. You can see the image in a T1 weighted image like this, or in a T2 weighted image with a whitish appearance like this. Ultrasonography is useful, particularly for follow-up of these patients. You can do it yourself and you can see how the cyst is reducing and gradually merging with the surrounding muscle structure. You can find out that the disappearance of the cyst takes much longer than the clinical disappearance of acute inflammatory signs, and it may take up to 6 to 9 months for the total disappearance of the cyst. Some inflammation, though, may still remain, some fibrotic changes remain in the area possibly for much longer. Histopathology is possible only in those rare cases where there is a spontaneous extrusion or where a surgical excision is needed. Medical management today is the mainstay of treatment. Surgical removal was the norm till 1993. When I came across a case which was, so this is a patient who's had a lateral orbitotomy. This is some of my old slides. The first time I treated a patient with myocystic was one with a cysticercus very close to the apex, and the patient was Mr. Sani, still following up with me, and I thought it was too risky to go and venture near the apex, and thought of the albendazole treatment, taking a cue from the neurosurgical treatment, and those were the first treated cases of myocystic. There were no reports, and I presented my series of 21 cases in 1995 and got the Ramacharya Award for that. Today, I prefer a regime of 30 milligram per kilogram for 2 weeks rather than the 15 milligram per kilogram for 4 weeks, because I find the cure rates are much higher with this, and the side effects in terms of liver function are not significant. They are usually combined with low dose oral steroid. We do not use a much higher dose of steroids. So the response is exceptionally good in almost 97 to 98% cases, where you can see the disappearance of the proptosis here in the patient on the left and the treatment results on the right. The inflammatory signs disappear. The cysts which you see subconjunctivally, they tend to disappear after management. And the ocular motility restriction restrictions which are present, start responding, and within a few weeks to months, you are able to get rid of the ocular motility restriction. As you see here, left pre-treatment, right is the post-treatment. So ocular motility restrictions show a response a little slower than acute inflammatory signs. And you can see the reduction in the size of inflammation over a period of 4 months, where you're left with a thickened muscle, but the cyst has disappeared and the swelling has disappeared. Toxicity of albendazole is usually mild, and increase in liver enzyme levels is the only thing that you look for, and you find mild increase in SGOT-HTTP, but that normally does not have any clinical significance. Acute inflammatory response within days of start of the medical treatment is often seen, but probably in just about 2 to 3% cases with an acute inflammatory presence, inflammation like this, which responds well to the use of steroids. But rarely spontaneous exclusion of cysts also takes place. So it is important to have a high index of suspicion for myelocystic psychosis in patients who are in the endemic zone, diagnose it on the basis of the clinical features, carry out imaging, and the response to medical therapy is excellent. Hydatid cyst is a much rarer condition in India. It is caused by the larval stage of Echinococcus tapeworm, and you can get a classical picture of a large cyst in the orbit. It shows the characteristic double wall sign, a spoke wheel pattern, and the water lily sign. The serological tests are more reliable in hydatid cyst, and the tests do sometimes reveal a positive histology. Management is largely surgical by orbitotomy, and you can aspirate the cyst intraoperatively to debulk it to prevent its rupture during surgery, because a debulked cyst is much easier to dissect, and you need to remove only the endocyst. You can combine the medical management with the surgical management in order to combat the effects of spillage and the secondary effects thereof. And the results of the combined therapy can be quite gratifying. Once again, reiterating the invitation to the Asia Pacific meeting in Delhi, September 26 to 28. Thank you.